I want to apologize for Kaiser's medical director, Tracy Imley, who can't be here today for very good reason, and to remind you that our goals here are to prevent and better manage heart attacks, strokes, and diabetes. And increasingly, some of our patients are moving into heart failure, so we're cycling in that topic as well, in addition to our heart attack and stroke work. So to take it out of the theoretical, when I woke up this morning and I looked at my email, invariably on the day of a University of Best Practices, we get notifications that someone can't be with us for some reason. And this particular first email of the day was the reason that we gather. And that is that one of the lead physicians for Kaiser, the chief of family practice, Dr. John Karapetian, passed away unexpectedly this week from a heart attack. So it brings us to the gravity of why it's important for us to link arms as a community, or strongly in the right direction together to manage these modifiable risk factors aggressively. We need to get public education out there. We need to form a public service announcement campaign to warn people. These silent killers can now be managed, and we have the tools and technologies to know who is at great risk, and we need to aggressively do proactive outreach to them and encourage them that with knowledge is power. We now have incredibly powerful medications and treatments that can save lives, and in particular we want to work with the LA Department of Public Health. Dr. Tony Kuo is here with us today. He can't be with us for very long, but he has been our longtime co-chairman, and we also want to welcome back another longtime co-chair, Dr. Carol Keaton, who hails from England and most recently as the head of Innovation, Center for Innovation at the University of Southern California School of Medicine. So Tony, why don't you come on up and welcome our guests today, and thank you all for being here.
Thank you, Haley. As Haley mentioned, I don't usually get to come to this beautiful place, right? But maybe one day I'll work for them. I think today, we're in for a treat, partly because it's not just our two guests that's going to talk about the idea of actually having a pharmacist on a clinical team. I think this is not just a theoretical or just innovations that's come into task. This is something that the Department of Public Health and also at the LA County Health Agency, we've really been working with with this area to try to really promote comprehensive medication management approaches to really control blood pressure and to control the risk factor that actually leads to what Hattie says. And part of it is that, as you know, it's not so much that we need more randomized controlled trial studies or even like more specific data on it. What we are tasked with now these days is how do we actually disseminate and actually make these type of innovations and best practices available to providers and most importantly to the public and patients. So I think you'll get to hear from Dr. Jan Hirsch, done tremendous work in San Diego, and then of course Dr. Stephen Chen, whom I've worked with quite a bit and we continue to work with in trying to scale CMM. So I think, should we?
Could you talk a little bit about
about your work with Dr. Chen and Dr. Hirsch
Sure.
in LA County, and then Carol Peden will talk about their bios.
Yeah, as I mentioned, the health agency and the Department of Public Health has been very interested in this arena. It's been a number of years. In 2014, we actually received the Center for Disease Control and Prevention grant, where they were very interested in how can we actually impact system change so that we could do a better management of not only catching people with high blood pressure and a lot of these risk factors of cardiovascular disease, but actually be able to manage it not only appropriately, but on a more consistent basis. And so one of the things we started out with was thinking around medication therapy management programs, but then over time, as we learn more, and working with Steve, for example, USC, and actually with the state, across the state, we realized that what we're really talking about are things like one step even further than just medication therapy management, sort of comprehensive medication therapy. The pharmacist should be part of a clinical team and actually be on sort of the day-to-day management for patients. And then to add maybe even more to that is California is unique because there's advanced pharmacist practice. It's one state where the pharmacist can actually function in a provider format. And so that's another area we've been working with both our speakers and others in the state to try to push for it. So, okay, with that, so Carol, would you like to?
Thank you.
So thank you.
Well, I haven't had a chance to speak to Dr. Hirsch, but are you going first? Who is going first?
I think I am, because Steve is pointing at me.
Okay.
This is going to be a group effort.
It's
going to be a,
you know, we like innovation here. We like to.
yeah, we'll roll with
So
it.
I think this is a very exciting meeting. Working with pharmacists, I mean, my clinical background is an anesthesiologist, so pharmacy is really live when you inject a drug that can kill somebody straight into them, and you've got to get it right. So I've always worked very closely with pharmacists. It's incredibly important, as Hattie alluded to before I came here. I worked in the UK and I worked at a national level with NHS England, and on the top executive team, of which I was part of a region for 15 million people. My colleague that I worked most directly with was the clinical pharmacist, and the amount that can be achieved working with pharmacists in the community is amazing. So I think this is a very exciting meeting. You can see Dr. Hirsch's CV in front of you. It's very impressive. You can read it, just as I can, but she's Professor of Clinical Pharmacy Chair, the Division of Clinical Pharmacy at the Skaggs School of Pharmacy at University of California, San Diego. So I don't know if you drove up here this morning, but well done. And has multiple innovation. And also the thing that jumped out at me, and I think you're going to talk to today, is about your work in the community, but many other awards and work with industry. So we'd like to welcome you, and we're very interested in what you have to say. And the combination of having you here with Dr. Chen is a great opportunity. So thank you.
And I will just add that Jan was one of our co-principal investigators in our initial National Institutes of Health grant back in 2009. So she's been part of the RightCare family for almost a decade now, and we have so enjoyed working together, and she's just a powerhouse in getting people to work collaboratively together who don't think they need to be working collaboratively together for the betterment of patient lives. Thank you, Jan, for making the effort.
Thank you for inviting me here. And I have to say, everybody that knows Hattie knows that what she just said is that she is the one that gets everyone to collaborate. And when Hattie calls, you pick up the phone. So I am here.
It's very sweet, thank you, but it really is a we thing. It's just everybody who has the heart for this work coming together, making it work in our incredibly busy lives. I mean, it's hard to prioritize saving lives, but it is the right thing to do, and I'm just so grateful that all of you are in this with us.
And it definitely has been a collaborative since 2009. I really hadn't thought back that long. So I've met a tremendous number of people, people from different walks of life, different organizations. The more I've been involved in this, that I never even knew existed. You know, and making those connections has just been, Right Care Initiative has been great. And so my heart is in it, as you would say. So, okay, so today we're going to talk about kind of an update. Pharmacists on the care team we've been talking about since the very beginning. The pharmacist on the care team was one of the initial promising innovations. And as we've come through the years, it's become more than promising, as Dr. Kuo mentioned, that you know, we are to the point of dissemination. We're to the point of moving on from just randomized trials. You know, we still need some evidence, but we have enough evidence that now we are actually implementing and looking at the outcomes from those implementations. So I'm going to give you a few updates, and Steve and I are going to, when I say Steve, please come up. Steve's going to be doing his part, all right? So I'm working him in here.
So before she gets into her slides, I just want to say that Steve Chen has also been a longtime member of our leadership team and our host at USC for many years. We've had recent fun together up at the Capitol testifying for the importance of this. And actually, I just thought, gosh, we should have had Tony Kuo with us, and maybe we'll work that in the next couple of weeks. So Steve is these two are amazing, longtime pillars of the Right Care initiative, and with that, I will stop interrupting you and let you proceed with this amazing data.
It's no problem, because I think that's what we're about, is actually talking to each other on this. And Steve and I have worked together over the years, and I think Right Care Initiative has really helped us work together between UCSD and USC. You know, we've become much closer and know the other schools, and our work is very, very similar. May I proceed? Okay, here we go. I have no disclosures. Okay, so we're going to talk today. We have an hour and a half, I think. And there are three things. Three specific objectives. First, I passed out the new Pharmacists on the Care Team brief. I'm going to go over that. Steve is going to highlight one of the studies on here, and the others we'll touch on briefly, so everyone will be aware of what's in the new brief. And then I'm going to give you an update on actually your project. This came out of the LA University of Best Practices. We're doing a study which is sponsored by United Healthcare, and Jeff Mason is here. I'm very glad to see he's here because Jeff has been spearheading this for many years now, and we're getting close to actually enrolling patients now. So I'll give you an update on where that is. And then at the end, the third objective is I really want to talk about moving forward, just as Dr. Kuo said, moving forward with more implementation efforts. And one of the implementation efforts that Hattie is very keen on, and I know Dr. DeMaria and San Diego is in actually looking at collaborative care protocols around hypertension with pharmacists that are in the community. So community pharmacists working with community physicians, PCPs. And I'll tell you a little bit about that initiative, how it's moving forward, but also I'm going to ask you to do some work because I need some of your thoughts, and we are moving ahead a little bit with the California Department of Public Health and gathering some information of how we can make this happen. So really three very distinct objectives. Okay. So let's get started with going over the brief, the new Right Care Initiative Pharmacist on the Care Team brief. You have it in front of you, 2 pages, handy dandy pages. As I mentioned, when Hattie calls, you jump. Hattie called, Steve, when was this? March, April.
For this one, you mean?
Yes, because you were working We needed the brief updated.
That's right.
We needed the brief updated because Steve was using it with some legislation that he's going to tell you a little bit more about on that. And Hattie called and said, we need to get this thing updated, and we need to do this like in 5 days.
Well, that's because he asked me to testify about this at the legislature, and I looked back into our stuff, okay, what did we say? And I'll just bring our project brief on this, and I thought, oh my gosh, we've done so much since we last updated it, and I can't bring this to the legislature with it being so outdated. So Jan and Steve and Megan and Brian and our UC Berkeley team all worked together to put together some pretty compelling data, which we hope will help to make it more available to Californians generally.
So this is pretty cool. There are lots of other studies that could have been included on here. Some of these are because we've known them, we've been talking about them, some of them because they're new. Steve's going to tell you about one very new one. But it is just it's a sampling of what's out there now in the literature about the pharmacists on the care team. There are so many articles that could have gone on here, but these are focused obviously on the RightCare initiatives of lowering lipids, improving blood pressure, and improving glucose control. So, 528.4 billion, I've already been asked about this number. $528.4 billion. That is the cost of illness and death that result from non-optimized prescription medication therapy. That's a ton of money, 528.4 billion. And what's in that is, in those costs, these are downstream costs from when prescriptions are prescribed in the United States. Some of them do, the first bullet point, they actually achieve their desired outcome, and that's good news. But then others actually are causing new medical problems. The medications themselves are causing problems. Or the other category you can go into is the prescription was prescribed, but it fails. And because of these medications causing new medical problems and treatment failure, there's a whole cascade of downstream costs that are involved. And those are going back to the physician, going to the ER, it could be long-term care, it could be hospitalization, ER visits. All of those are long-term costs, and all of that is in the $528.4 billion. Okay. And what the pharmacist on the care team is all about is trying to reduce some of these avoidable costs. And obviously, the ones we're trying to avoid are the medications that are causing new medical problems or treatment failures. So the whole goal of the pharmacist on the care team is to help optimize medication therapy and certainly improve patient outcomes and our quality indicators, but also reduce this number. This is a huge number. It is equivalent to 16% of our healthcare expenditures as of 2016. And I have one note on here is it has been widely, the figure before, so my colleagues and I, we updated this number and it's been recently published. But the previous number that you've probably heard over and over and over is 290 billion. And that was about 10 years ago. Right? 290 billion. And almost, well, many times I read it and it says, the cost of non-adherence, 290 billion. That's wrong. It is not the cost of non-adherence. What it is, because we went back and updated the entire model, so I know exactly what's in it, it is these three things. It is the cost of using medications correctly to have a good outcome, and that's about 60% of the cases. The other 40% of the cases fall into you caused a new medical problem because of the medication, or it failed. Now, adherence is in here. It's certainly it is a reason for some of these treatment failures. And it can be a reason for maybe new medical problems developing. But that number is not the cost of non-adherence. That's my first and only soapbox, probably. And as I said, this is what we're trying to address.
So I'm sorry, the first bullet there, though, the first item, medications achieving desired
Yes.
outcome, you are measuring something in that because
Yes,
these
there are
are costs
costs.
of non-optimized, right?
Yes, the whole thing, basically, yes. Okay, so moving on. So here are the studies that have been added to the pharmacy brief. and we're not going to go over all of these in detail. But it's certainly all around kind of blood pressure. We have some from the barbershops that I'm going to ask Steve in just a second to come up and tell us in detail. We have some looking at telemonitoring, and we've talked about this study somewhat in the past. Recently hospitalized patients, there's a great Kaiser study, reducing hospitalizations also, and this is CMMI that Steve was also involved in. This is his study, which I'll also ask him to talk about briefly. And then looking at it from kind of the insurer also. So we have different perspectives in these studies too. The hospital, caregivers, and the insurance. And then looking at also, we've added diabetes, which we didn't have on here before. We didn't have that cardiovascular and diabetes focus. So we tried to get sort of a large array of studies. So here is the study which is called the barbershop study. And I'm going to let Steve come up and talk about that and specifically. Come on up. This is the little blurb, and this is in the briefing. Basically what we tried to do is we tried to give like a one-sentence overview. Okay, this is what happened, and then some sort of visual that people can look at pretty quickly and say an intervention group, the control 90% versus the control group 32%, and then all of the references are in the back here, and then I'm pretty sure these references are actually posted on the RCI website, right? Yeah. No. Okay, I'm going to turn it over to Steve.
Thank you. I was just wondering, can you hear me if I step away? Because I can't see anybody over here. So I'm going to kind of hang over here so I can see you a little bit. So first of all, let me clarify, this is not my study. This is Dr. Ron Victor, who's over at Cedars-Sinai. Anyone from Cedars here, by the way, in the room? Okay. Oh, that's right. Okay. How are you? Dr. Victor would love to have been here, but was unable to be, and he was very excited about the study. He's had an amazing career. I was lucky enough to, I don't know if you went, but they had a symposium for him in honor of him about a week or two ago. I went, it was basically a tribute to Dr. Ron Victor, and I learned that he had about 5 major contributions to the field of cardiology. So I asked him afterwards, where does this rank of all these amazing things you've done? He said, number 1, no question. So I'm going to go over why he feels so good about it and why you should feel good about it too, because it's pretty amazing work. So just for background, I think we already know a lot of this. Hypertension-related death rates account for, well, let's see, about half of all heart attacks and 3/4 of all strokes can be attributable to uncontrolled hypertension. So there's a pretty simple correlation between do a better job controlling blood pressure in your population, you get less heart attacks and strokes. There's, in the Black population, a lot less physician interaction between patients and providers. You have, among Black patients, more undetected high blood pressure, more uncontrolled high blood pressure, and a lot more heart attacks and strokes in that population as well. And so Dr. Victor was dedicating himself to shifting from more bench research to practice-based research, and decided I want to figure out how to solve this problem of the African American male having the worst outcomes from hypertension. And that led him to the barbershop idea, looking at that as an opportunity to engage patients. Well, before I get too far, let me give you a little bit more background. When he was in Texas and had first thought of this idea, he found almost 20 barbershops that were willing to participate in this program. He trained all of them on how to screen patrons for hypertension. For all of the patrons, if they had high blood pressure or blood pressure above goal, they would be given NIH-approved information on the importance of managing hypertension. And then for half, they would get an appointment scheduled with their primary care provider. And if patients showed up for those appointments, they get a voucher for free haircuts for 6 months. So it's just a nice incentivized system. He thought this would be so easy. He ran this for a year, and after that time looked at the data and said, well, gee, there is a difference in blood pressure control, but the magnitude difference in systolic blood pressure was 3 millimeters of mercury. So when he looked closer, he couldn't understand why. What he figured out was, even though the patients went back to their primary care physicians who had high blood pressure, nothing was done to the medications. There were essentially no differences in number of meds. So he came here, he was recruited heavily by folks at Cedars to run their hypertension, heart failure program. And through a series of connections, Rita Shane, of course, Rita assertively went to go meet him, find out what he was doing, and said, well, maybe you should talk to Steve, because it sounds like this is an underserved population, and USC's been doing a lot of work here. So we talked about the idea of what if a pharmacist does the medication management for hypertension. And he was not familiar with it at all, and I started giving him the idea of the background. And he on his own went and researched, does this really work? And he came back to me and said, look, there are 40 or 50 good trials out there, most of them government funded, that show adding a pharmacist to the team to manage hypertension really results in a night and day outcome in blood pressure. So he was sold. He ended up collaborating with several people at Kaiser that helped develop the program further with him. And the idea here is that this is a team-based model. This isn't a one-off where a pharmacist is doing something independent from the group. This is under a collaborative practice agreement. And I think, how many read the study, by the way? How many have actually read? Okay, it's a few people, so I think we can go over in more detail. But he did publish this, the results, a couple of months ago in the New England Journal of Medicine. This is the general construct of what he did. It was similar to what happened in Texas, where he had barbers screening patrons for high blood pressure. The difference was that instead of having the primary care providers follow up, half would get usual care and half would have their medications managed by a pharmacist. So I should have been more clear, but backing up a little bit, this is an $8 million NIH-funded study, and the way that he got funded is one of our former residents worked with him for a year and worked with about 10 different PCPs and barbershops, mainly in the Pasadena area, and was able to get enough pilot data to show that the differences in systolic blood pressure when patients are managed by pharmacists are at least 10-15 millimeters of mercury, at least in that range. So that was used to rationalize the grant which he received. So what we're seeing here is a 6-month follow-up. And just so you know, there's an extension, a 12-month follow-up, and it looks just as good. The blood pressure gains have been continued, and that hasn't been published yet. So some of the secret sauce to what works, and he loves to talk about this, he's done a lot of research on community, on patient engagement, and he found this to be very effective. He creates these role model posters that he puts in the barber shops to engage the patrons in the program. And they're quick, short testimonies about how personally this program impacts the given individual, kind of gets to the bottom line of what they felt was valuable about it. And these, he said, have been very effective in terms of getting patients interested in being part of the program. The other gizmo they put together that made this really easy is they gave every enrolled member a barcoded card with their information on it. And all the barber would have to do after the patient finishes his haircut is the patient would be relaxed, and the barber would bring this device over, put the cuff on the patient's arm, swipe the barcode card, and walk away. And then there'd be a series of 5 blood pressure readings taken over the course of a decent amount of time. The last 2 would be averaged, 2 or 3, I can't remember now. 2 would be averaged, and then that data would go right to Cedars-Sinai, and barber would not have to worry about any of it. So it's really nicely done, all set up by Cedars-Sinai. What did the pharmacists do? They maintain at least monthly appointments with those patients that were in the intervention barbershops. They check blood pressures under a full scope collaborative practice. They would manage medication therapy. That means add medications, subtract, modify doses. They monitor electrolytes using an iStat portable device, so very much a, I guess, Theranos, but actually works kind of device, right? Relatively inexpensive. Progress notes were sent within 24 hours to the PCP. And then we had a pharmacy in South Central that delivered in the South Central area, owned by one of our alumni. So that was a really nice plus for this project.
Steve, I'm sorry to interrupt you, but why the electrolytes? Nobody's ever mentioned that in 10 years of RightCare meetings.
Okay, because of all the, if you think about all the medications used in high blood pressure, if you're going to monitor them for safety, your Chem 7 pretty much covers all of it, right? So the electrolytes that you can get in a simple Chem panel are just about all you need. Now you can argue maybe your analysis, some other things might be helpful, but this is essentially at the core of what you need to make sure that your medications are being used safely and you're not having side effects and that sort of thing.
And you can do that right in a barbershop?
It was done in the barbershop, correct.
How about that?
How about that?
Isn't that something?
It is. It's a nice tool. It worked very nicely for that.
Steve, did you mention that did the barbers get paid for this, or it was just a 6-month free haircut?
The barbers did get paid. There were incentives throughout, so patients that signed up got some kind of incentive. If they maintained or followed up, they got incentives, and the barbers got paid as well, yes, absolutely. So Dr. Victor at one point was saying, I need to rally for barbers being recognized as healthcare providers. So, pharmacists first, right? So he's still working on that. So here's his sort of his secret algorithm, which is really not a secret, right? The first step was calcium blocker and Arbor ACE, and his preferential calcium, everybody, is usually amlodipine, but he was very sold on telmisartan. Not that he mandated that everybody be on telmisartan, but it really is the most potent, longest acting, definitely his favorite. So if it could be used and it was available on formularies, it was the drug of choice. The second, probably less recognized, is indapamide, was the thiazide type diuretic of choice. Again, it's much more potent than hydrocodone.